Today we are going to start the headache. What you should know about headache, guys? First of all, what is the Latin name of headache? The Latin name of headache is what, guys? It is your cephalgia, right? And I know, guys, this topic is very easy for you, and we already have revised this topic in class around 3 to 4 times, right? So we'll make it fast and we'll try to complete it before 12 o'clock. Okay. The headache is what, guys? Headache is cephalgia, and it is happening due to what, guys? What is the reason behind it? The reason behind it is irritation, guys. Where I'm going to have this irritation? I'm going to have this irritation on my dura mater, guys. The irritation of dura mater is going to make me feel pain inside my head, right? What you should know here, why only dura mater irritation is making this, guys? Because at the dura mater we are having the nerve endings. So nerve endings are present at dura mater. These nerve endings will send what, guys? Pain signal. This nerve endings will send pain signal to your brain, and that's how you are going to feel headache. Okay. What is dura mater, guys? Dura mater is your meninges, right? The covering of the brain is known as meninges, and we are having total how many meninges? We are having total 3 meninges. What are the names, guys? So the outermost layer is what? Outermost layer is your dura mater, right? The middle one is your arachnoid mater, and the last one is your pia mater or pia mater, whatever you want to say. All these three are what, guys? All these three are the layers of the brain. Done, guys? Now, this headache can be of two types. What are these two types, guys? So the headache can be either the primary headache or the secondary headache. It can be primary or it can be secondary, right? How to remember primary headaches and secondary headaches, guys? For that, I am having mnemonic, especially for the primary headache, that is TMC. Terry Mummy Cute Hai. TMC. What is T? What is M? What is C, guys? T is for your tension headache. M is for your migraine. And C is for cluster headache. Tension headache, migraine, and cluster headache. This is according to most common to least common, right? What about secondary headache, guys? So secondary headaches are happening due to what, guys? The secondary headaches are happening due to some other reason. And what are these reasons, guys? It can be either due to trauma, it can be due to hemorrhage, it can be due to infection. If your intracranial pressure is getting increased, so ICP is getting increased, that is also a reason for your secondary headache. And the last thing is what, guys? Last thing is either tumor or the cancer of your brain. All these things will do what, guys? All these things will increase your headache when you will call it a secondary headache. Okay. Out of them, infection is important, guys. And out of infection, one very, very important infection which is asked in FMG exam, that is what, guys? That is meningitis. Inflammation of the meninges of brain, that is known as meningitis. Okay, why it is important? Because meningitis can be from bacteria, it can be from fungus, as well as virus. That's why you should know how to diagnose meningitis. It is very important medical condition for your FMG exam. Next is intracranial pressure, guys. What you should know about intracranial pressure? For intracranial pressure, first of all, you should know when we will say that the patient is having high intracranial pressure. So whenever the patient is having blood pressure more than 180 by 120, so the patient is having more blood pressure around 180 by 120. In this kind of condition, the patient is going to have increase in intracranial pressure also. How you will treat it? It is important, guys. So the drug of choice for increase in intracranial pressure, that is what, guys? That is your intravenous mannitol. And when we give intravenous mannitol, what is mannitol, guys? Mannitol is a beta blocker. So we are giving intravenously mannitol to a patient who is having intracranial pressure increase. Now, let's discuss all the primary headaches one by one, guys. So what we are going to discuss? We are going to discuss primary headaches. Out of them, the first one which we are going to study, it is what, guys? It is your tension headache. Right? What you should know about tension headache, guys? Tension headache is your most common primary cephalgia. It is the most common primary cephalgia. Who gives tension, guys? It is girl or the boy? Can you answer it in chat? Of course, girls are giving more tension than boys, right? So tension headache is found more in girls than in boys. Next is your duration of this headache. The duration of headache is what, guys? It is your minutes to hours, right? This kind of headache will be featureless. This kind of headache is what, guys? It is featureless. What does it mean? It means that the patient is not going to have any kind of vomit, patient is not going to have any kind of nausea or no vertigo, or you can say dizziness. So patient is not going to have any kind of vomit, nausea, vertigo, as well as you can say dizziness, right? Now, where this pain is going to happen, this will be bilateral. So on the both hemisphere of my head, this pain is going to happen. Okay. How you are going to treat this thing, guys? For treatment, remember, guys, T for tension, T for tablets. You are going to use tablets for this kind of headache, guys. So The treatment is your non-steroidal anti-inflammatory drugs, NSAIDs. How you are going to give this NSAIDs, guys? You are going to give this NSAIDs orally. And what are the NSAIDs you should know? It is your paracetamol, it is your ibuprofen, acyclophenate, diclofenac, or you can use aspirin also. Why we don't use aspirin, guys? Anyone who can answer me in the comments why we are not using aspirin in the treatment of an tension headache? It causes Ray syndrome. ज़्यादा पढ़ लिया खुशनुमा तुमने. Guys, as we all know that aspirin is most useful in your chronic hypertension, right? So if a person is using aspirin from childhood only for such minor headache, in future when this person is having hypertension or the chronic hypertension, now aspirin will not work properly, right? It is most probably in the use of blood thinners. So guys, one thing you should know about aspirin is having two different works, how it will work. So if you are having it in high dose, it will work as NSAIDs, and if you are using it in low dose, then what will happen? If you are using it in low dose, it will work as a blood thinner or anticoagulant, right? So whenever this person is taking aspirin for headache, the person is taking it in high dose, of course, right? After some time, what will happen? Aspirin will get metabolized inside the body and it will automatically convert into the low dose. Once aspirin will convert into low dose, it will give me the action as a anticoagulant. The patient's blood will get thin. If patient's blood is getting thin and if this patient is getting injury or getting trauma somewhere, what will happen? This patient will have very high amount of blood loss because it is very thin. It cannot coagulate properly, right? That is all about the tension headache, guys. The second thing which you are going to study is what, guys? The second thing which you are going to study is your cluster headache. If you are writing the notes with me, guys, so how should we write cluster? That's how you are going to write the cluster, guys. Why we are writing cluster like this? Because it is, anyone who can answer? Because it is more common in boys than in girls, right? This kind of headache, the cluster headache, is going to happen in the boys. And what you should know about it, the duration of this headache. The duration of this headache will be what, guys? It will be your seconds to minutes, right? This kind of headache will always and always on one side of your lobe, not on the both lobes of brain. Okay, one hemisphere of the lobe, one hemisphere of the brain, right? If it is having only seconds to minutes, it is short acting headache. It is short acting headache. What you should know, guys, this kind of headache will never last more than 3 hours. This kind of headache is not going to last more than 3 hours. Okay, so it is more common in boys. It is happening from seconds to minutes. It will be unilateral. It will never last more than 3 hours. What else you should know? You should know the clinical features of this headache, guys. So it is happening in boys, right? Boys will have what, guys? Boys will have red eyes. Boys will have increase in tears. It will feel like boys are crying, right? Plus, very, very important thing, that is what, guys? That is your severe retroorbital pain. Severe retroorbital pain. What does it mean, guys? It means that behind the eyes, I am going to have very, very severe pain. This pain will be that much severe, guys, that a person will feel restless. Person cannot sit even with the rest. You understand, guys? So he will be moving here and there. He will be, punching and getting angry, getting anxious, that why this headache is happening, I just want to get relief from this headache. All those things will happen to this kind of patient, right? What else you should know, guys? This kind of pain, somebody has already written rexy. So this kind of pain will be periodic in nature, guys. What does it mean? So suppose I am the patient who is going to have this kind of pain. If it happened for the very first time today to me, after 10 days, 15 days, 5 years, 10 years, it will happen again and again and again to me. Okay, so it will be a periodic pain. But what you should remember here, guys, it will be periodic but on the same time. So today I am having this headache in the morning. So whenever in my whole life I will have this kind of headache, it will be always and always in the morning, always on the same time. This kind of headache is also included in TAC, guys. This kind of headache is also included in TAC. What is TAC, guys? TAC is your trigeminal autonomic neuralgia or cephalgia. Trigeminal autonomic cephalgia. What all things you are going to see here, guys? You are going to see the patient is having red eyes. The patient is having rhinorrhea. The patient is having nasal congestion. And the patient is having epiphora. Red eyes, rhinorrhea, nasal congestion, and epiphora. In epiphora, this patient is going to have two things, that is increase in the tears as well as increase in lacrimination. Done, guys? So once this kind of patient is there in the hospital, how you are going to treat this patient, guys? What is the treatment? Please write it down in the comments, guys. So the treatment is 100. The treatment is 100% high flow oxygen with triptans. 100% high flow oxygen with triptans. But what will happen, guys? This is very short term period of headache, right? So if this kind of headache is happening to a person, and if this person is not able to reach to the hospital, how he will treat himself or herself? For that, we are going to have one prophylaxis drug which you should know, guys. And this prophylaxis drug is what, guys? The prophylaxis drug is your calcium channel blocker. And name of this calcium channel blocker which you should know here, if anyone can say, guys, what is the calcium channel blocker which we are going to use here? That is your Verapamil, guys. Very good. The calcium channel blocker which you are going to use is what, guys? It is a Verapamil. Done. That is all about your cluster head. Now, let's come to everyone's favorite topic, that is migraine. In migraine, we are going to study with which color? Tell me, which color, which color? Why we are studying migraine with pink color, guys? The reason behind this is, out of 10 girls, 2 to 3 girls out of 10 will have this kind of problem, guys. So in every 10 girls you will find 2 to 3 girls, those who are having migraine in their life, right? It is more common in girls than in boys. Migraine is second most common primary cephalgia. Done, guys. Now, let's study about the pathophysio of the migraine, guys. From here, one question can come about migraine. What is the pathophysio of the migraine, guys? What will happen? Some kind of stimulus or some kind of trigger will attract to the, or will, so this person will have some kind of stimuli or the trigger. What can be the stimulus or the trigger, guys? It can be either the sound, it can be smell, and what else? Sound, smell, and light. All these three things can happen. Sound, which sound will trigger this person? It will be a loud sound. Smell, any smell can trigger. Light, flashy lights which you will see it in nightclubs. All those lights, the laser lights, this kind of lights will do what? Some kind of stimulus or the trigger to the person, and because of this trigger or stimulus, what will happen? Some kind of pathological electrical activity will happen. Where this pathological electrical activity will happen, guys? This pathological electrical activity will happen inside the brain. And when this kind of activity will happen, because of this, what will happen? What is the name of the peptide? Yes, it is what, guys? It is your CGRP. It is calcitonin gene related peptide. So let's write the full form, guys. The peptide name is calcitonin gene related peptide. Because of this calcitonin gene related peptide, what will happen? Because of this peptide, the patient is going to have inflammatory changes inside the brain. this patient is going to have the inflammatory changes, as well as this patient going to have vasodilation. Both of these things will do what, guys? Both of these things will stretch or irritate the dura mater, and because of that, what will happen? Because of that, the patient will feel pain or cephalgia. Done, guys? Any problem in this? So this is the pathology, guys. So pathophysiology, some kind of stimulus or the trigger is going to attack, or it is going to happen to that patient. Because of that, what will happen? Because of that, some kind of pathological electrical activity will happen inside the brain, and this pathological electrical activity will do what? It will secrete a kind of peptide. The name of the peptide is what? The name of the peptide is calcitonin gene related peptide. We call it CGRP, and this calcitonin gene related peptide is going to give some kind of effects to the brain. The effects are inflammatory changes as well as the vasodilation, right? So if the patient is having inflammatory changes and the vasodilation, what will happen? It will try to stretch my dura mater, as well as the dura mater will get irritated. And once the dura mater will get irritated, all of us know that the nerve endings are present there. And if my dura mater is getting stretched or the irritation, this nerve endings is going to give what, guys? This nerve ending is going to give the signal of pain to the brain, and that's how the patient will feel headache, right? Now let's discuss the diagnostic criteria of headache, guys. So in diagnostic criteria, we are going to have two things. These two things are the things from which girls are very obsessed. Now everyone knows because everyone has taken the classes. So can you tell me these two things which are the greatest obsession of the girls? Nice, nice. So the two things which are the greatest obsession of the girl is what, guys? It is the money and weight. And we have one unit which is common in money and weight. And the name of that unit is what, guys? Name of that unit is pound. And this is your diagnostic criteria. POUND, pound. What is P, guys? P is the nature of this headache. That will be what, guys? That will be pulsatile. So this patient is going to have pulsatile headaches. O is, guys, the duration of the headache, which will be at least 1 day duration. At least 1 day duration. U is what, guys? U is your unilateral. N is the signs and the symptoms which we are going to see in this headache. The symptoms are what, guys? The symptoms are vomiting. N is what, guys? N is your nausea and vomiting, right? N is your nausea, vomiting, or what else can this person can have? Vertigo, or you can say dizziness. Nausea, vomiting, vertigo, dizziness, all these things can happen. D is for disability to do routine work. D is for disability to do routine work. That is about the diagnostic criteria. Now, the next thing is what, guys? Next thing is the classical migraine. In classical migraine, this kind of person is going to have one very important thing, and this thing is known as what, guys? This thing is known as aura. What is aura, guys? Aura is a kind of intuition of having headache. Aura is a kind of intuition of having headache before headache. Intuition of having headache before getting headache. Right? That is your aura. After the patient is having this aura, the patient is going to feel some kind of sensory disturbance in his or her body. Patient is going to have some sensory disturbance. What are these sensory disturbance, guys? These are scotoma, flashes, photopsia. The patient can have scotoma, the patient can have flashes, photopsia, the patient can have tingling sensation, or the patient can have numbness. All these things are the things which can happen to a patient when this patient is suffering from classical migraine. First of all, the aura, then the sensory disturbance out of them, which what all sensory disturbance can happen: scotoma, flashes, photopsia, tingling sense, and numbness. Right? After this sensory disturbance, the last thing this person can have, that is what, guys? That is the headache. Now this person will have headache. And what you should know about this headache, guys, this headache will be pulsatile in nature, right? This kind of headache will get worse with movements. The patient can have fear of light, that is known as photophobia, as well as fear of smell, that is osmophobia. Pulsatile in nature, worse with getting movements, photophobia, and osmophobia. Right? Now, before discussing the treatment, you should know the severity of the headache, this migraine, guys. So, you are going to discuss, we are going to discuss what? We are going to discuss severity of migraine. This severity of migraine is going to happen if the patient is having less than 5 times per year. It is normal, guys. If the patient is having 5 to 12 times per year, it is mild. If the patient is having 12 to 48 times per year, it is moderate. And if the patient is having more than 48 times per year, it is severe migraine. That's how you are going to discuss about the migraine. We are going to treat the migraine according to this also, according to the severity. So 5 is normal, 5 to 12 is mild, 12 to 48 is moderate, and more than 48 is severe. For treatment, you are going to ask the patient some questions, and from those questions you are going to decide, is it a mild or the moderate or the severe migraine. So for mild to moderate migraines, what will be your approach, guys? For mild to moderate migraines, the approach for treating the migraine will be, first of all, you are going to start with oral NSAIDs. Then you will wait for some time. If it is working very good, if there is no relief in this, guys, you are going to give IV or IM NSAIDs. Remember, guys, if you are giving IV NSAIDs, always and always dilute the drug if you are giving it IV. Okay. Even after IV or IM NSAIDs, there is no relief. What you should do? The only option which will be here with you all, that is triptans. What are triptans, guys? Triptans are drug of choice for migraine. So if someone is asking what is the drug of choice for the migraine, it is your triptans. It is what, guys? It is triptans. What all triptans or what all drugs you should know in triptans? So we are having sumatriptan, we are having naratriptan, we are having alitriptan, we are having rizatriptan, and the last one is forvatriptan. Sumatriptan, naratriptan, alitriptan, rizatriptan, and forvatriptan. Out of them, alitriptan and rizatriptan, remember guys, both of them are fastest acting drug. And forvatriptan is what, guys? Forvatriptan is longest acting drug. Even after triptans, if the patient is not getting relief, as well as for moderate to severe patient, in moderate to severe patient, you can use IV, IM, NSAIDs. If they are not working, then triptans. Even if triptans are not working, then what you are going to give? You are going to give a poison to the patient. And the name of that poison is what, guys? It is ergotamines. You are going to give ergotamines to the patient. What this ergotamines will do? Ergotamines are potent, or you can say powerful vasoconstrictor. So ergotamines are what, guys? Ergotamines are very potent or powerful vasoconstrictor. Last thing you are going to remember here is, guys, prophylaxis. For prophylaxis of migraine, you are going to use what? You are going to use propranolol, and that is your beta blocker. We are going to tell that person to use propranolol every day once, ताकि उस पेशेंट को कभी माइग्रेन का अटैक आए ही ना. ठीक है. And that's how we are going to finish our primary headaches. Next is secondary headache, which we are going to start in few minutes. For secondary headache, guys, we are going to let my pencil get charged. So we are having 5 to 7 minutes break. In 5 to 7 minutes, we are going to have secondary headache. So in secondary headache, what we have studied, secondary headache is due to some other reasons, right? These some other reasons are what, guys? First of all, we have discussed it is trauma. So if a person is meeting with the accident, that person can have the headache. Next is your hemorrhage. This hemorrhage we are going to discuss further, right? Then we are having infection. What we have discussed about infection, we have discussed meningitis here. Then we are having increase in intracranial pressure. When you will say that a patient is having increased in intracranial pressure, the patient is having blood pressure more than 180 by 120 mmHg, millimeters of mercury, right? And if a person is having tumor or the cancer, all this kind of person will have the secondary headache. What we are going to discuss, we are going to discuss about hemorrhage. Which hemorrhage we are going to discuss, guys? So we are going to discuss about intracranial hemorrhage, the hemorrhage which is going to happen inside the brain. Intracranial hemorrhage. In intracranial hemorrhage, what all things we are going to study? First of all, we are going to study EDH, then SDH, and then SAH. What is EDH, guys? EDH is extradural or epidural. Extra or epidural hematoma or hemorrhage. SDH is what, guys? SDH is subdural hematoma or hemorrhage. What is SAH, guys? SAH is subarachnoid hematoma or hemorrhage. SAH is subarachnoid hemorrhage or subarachnoid hematoma. Now, where I am going to have this EDH, guys? EDH is going to happen in above the dura mater. So, outermost layer is dura mater. Above this outermost layer, I am going to have the hemorrhage or the hematoma, right? Above the dura mater. SDH will happen below the dura mater. SAH will happen below the arachnoid mater, right? Above the dura mater means what, guys? This kind of blood clot you are going to find between bones and dura mater. SDH you will find between dura mater and arachnoid mater, and SAH you are going to find between arachnoid matter and pia matter. Done, guys? Let's discuss everything one by one. So first of all, we are having EDH. For EDH, you have to remember one mnemonic, and the mnemonic is my mama makes the best idli. So in this kind of hemorrhage, epidural hemorrhage, what will happen? In epidural hemorrhage, I am going to have the rupture of the artery, and the name of artery is what, guys? Name of the artery is medial meningeal artery. So I am going to have the rupture of medial meningeal artery, right? How this medial meningeal artery will get rupture, guys? Medial meningeal artery can get rupture mostly secondary to your temporal bone fracture. It is going to happen mostly to temporal bone fracture. Done, guys? Now, what else you should know? Here you should know the weakest part of your skull. So the weakest part of the skull is what, guys? The weakest part of the skull is terion. Terion is what, guys? Terion is combination of four different bones. So four different bones are going to come together and attach together. That's how terion will make. Try to remember, guys, this terion, just behind this terion, can you see this? The fingers are the terion, and this white pen is my medial meningeal artery. What I am going to try to say, guys, here, it is that the medial meningeal artery is going to pass just behind, just posterior to your terion, right? So on the posterior side, you are going to have what? You are going to have medial meningeal artery. Now suppose, guys, there is a guy who is going to have the accident, and this guy was riding the bike without using the helmet, and he got some kind of injury on his head. And when we discussed this injury, we saw that the weakest part of this person, the terion, got fractured. Once terion is getting fractured, guys, just try to imagine any bone which is getting fractured. This bone will have sharp ends at the place, right? This sharp ends will get into the medial meningeal artery, and then medial meningeal artery will get ruptured. Once medial meningeal artery will get ruptured, what will happen? There will be very much amount of blood which will get collect inside the patient, inside the skull of the patient, right? Because of that, this patient can have cranial nerve number 3 paralysis. Cranial nerve number 3 palsy can happen. Medial meningeal artery is the branch of maxillary artery. Great. So once this person is inside the hospital, any person, guys, remember this thing, any person who is having the head injury, this kind of person is going to go through one investigation, and the name of that investigation is what, guys? Name of the investigation is CT scan of the brain. So once the patient is going to have this CT scan, the blood clot, the blood clot is going to, you are going to observe this blood clot. How, guys? This will be hyper dense area, guys. So the patient is going to have hyper dense area inside the skull, and this hyper dense area will be resembling what, guys? It will be resembling the blood clots. Done, guys? This kind of a patient is going to have one very important clinical feature, and the name of this clinical feature is what, guys? Name of this clinical feature is your lucid interval. What is lucid interval, guys? In lucid interval, the patient is going to travel between two different conditions. And what are these two different conditions here, guys? These two different conditions are the patient is going to have consciousness, unconsciousness, again consciousness, again unconsciousness, and consciousness. So patient will get conscious, unconscious, conscious, unconscious, like that in his time period, right? Once you will see the CT scan, guys, in CT scan you are going to have what, guys? You are going to have this idli shape clot. You are going to have the clot, and this clot will resemble what, guys? This clot will resemble idli shape. What else you can say? You can say biconvex shape, idli shape, biconvex shape. What else? Lentiform shape, idli shape, biconvex shape, lentiform shape, as well as this patient can have one more different shape. What is the name of that shape, guys? Anyone who can answer? It is your lemon shape. So all these four different kind of shapes you are going to see, where you are going to see in a person who is having EDH, epidural hematoma, right? Let me show you the photo also, guys, if I am getting the photo. See, guys, can you appreciate this hyperdense blood clot present in the CT scan? And this hyperdense blood clot is looking like a lemon shape or idli shape, or you can say what it is, biconvex shape, right? Biconvex shape, idli shape, lemon shape, and lentiform shape hematoma. This kind of hematoma is known as idli shape hematoma. One thing which you should remember here is what, guys? This hematoma will never cross the suture lines. This hematoma is not going to cross, never going to cross the suture lines. Done, guys? I hope no one is having any problem here. Let's see something about lucid interval, guys. So in lucid interval, what I'm trying to say you guys, this kind of interval is also seen in one condition. In that condition, what will happen? This person will go into depression, mania, depression, mania, depression. This kind of problem is a psychiatric disorder, and the name of this psychiatric disorder is what, guys? Name of this psychiatric disorder is bipolar disorder. In bipolar disorder, which drug we are going to use? In bipolar disorder, the drug of choice is the mood stabilizer, and the name of this stabilizer is what, guys? Lithium, lithium. It is your lithium, guys. It is lithium. Lithium is the drug of choice for bipolar disorder. This lithium is very important, guys. Why this lithium is important? Because in lithium, it is very toxic. If you will give it in high dose, the patient will get cardiotoxic. As well as this lithium is teratogenic also, guys. What does it mean? So if a person who is already pregnant, right, and already having this bipolar disorder, and in first trimester of his pregnancy, if this patient is taking lithium, this patient can have the baby of this patient can have some congenital cardiac disorder, and the name of this cardiac disorder is what, guys? Tetralogy of Fallot. In tetralogy of Fallot, what you are going to see, if you are doing the X-ray, you are going to see the boot-shaped heart. It is what, guys? It is boot-shaped heart, as well as you are going to see what, guys? You are going to see four different things. That is atrial septal defect, ventricular septal defect, right ventricular hypertrophy, and overriding of aorta. Overriding of aorta. All these four things are going to be seen in your tetralogy of Fallot. Okay, let's come back to the topic. If you are having the EDH, how you are going to treat this patient, guys? So for treating this patient, you are having two options, and both of them are the surgeries. First one is known as Burr hole surgery, and the second one is what, guys? Second one is your craniotomy. Both of them are the best treatment you can give to EDH. Next is your SDH. SDH is what, guys? SDH is your subdural hematoma. So now you are going to have rupture of what, guys? The rupture of bridging veins. Rupture of bridging veins will happen in subdural hematoma. What all kind of patients will come here, guys? So the patients which are going to come here can be elder patient, it can be alcoholics, it can be the patients with the blunt trauma or shaken baby. Try to remember one thing, guys, that the pressure of the arteries is much higher than the pressure of the veins, right? So if artery is getting ruptured, blood will come out fast. If veins are getting ruptured, blood will come out slow. So if blood is coming out slow, what will happen? This blood will compress the brain after some period of time. What is that period of time, guys? That is your FMG exam question, that the clinical feature will be unconsciousness. But this unconsciousness is going to happen after 2 to 4 days of injury. This unconsciousness is going to happen when, guys? This unconsciousness is going to happen after 2 to 4 days of injury. Done, guys? Next thing, when you will do the CT scan of this person, in CT scan you are going to find what, guys? You are going to find banana shape hemorrhage, or you can say crescent moon shape hemorrhage, or you can say sickle shape hemorrhage. Remember one thing, guys, all these shape of hemorrhage are known as subdural hematoma, and in subdural hematoma the blood clot will cross the suture lines. It will cross the suture lines. Now, the last thing which you are going to study here is what, guys? The last thing which you are going to study here, it is your subarachnoid hemorrhage. Subarachnoid hemorrhage is happening due to rupture of aneurysm. What is aneurysm, guys? So whenever the arteries are getting swollen, whenever the arteries are getting bigger, it is getting swollen, and this swollen arteries will get ruptured. So the swollen is known as swelling in the arteries is known as aneurysm, and the rupture of this swelling is known as rupture of aneurysm, right? This aneurysm will be found where, guys? This aneurysm will be found in the circle of Wills in your cow, right? If to be specified, 40% of the time this aneurysm will be on your anterior communicating artery. Done. Now, what all are the patients or where you are going to see this, guys? You are going to see all these things in autosomal dominant conditions. Out of them, the first one is Marfan's syndrome. And in Marfan syndrome, which chromosome will get affected? It will be your chromosome number 15. The second thing here you would know is what, guys? It is ADPCKD. That is what, guys? That is autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. So in this kind of patients, you are going to have what? You are going to have subarachnoid hemorrhage. One thing you should know about subarachnoid hemorrhage is it is never going to see in CT scan. It is not going to see in CT scan. Where you will see this kind of thing, you are going to see this kind of thing in MRI. In MRI, that too, it should be N2 scan. In MRI N2 scan, you are going to see this kind of thing. Okay. What else you can do? You can do one more thing, that is lumbar puncture. So in lumbar puncture, what will happen, guys? When you will take the first of all, lumbar puncture is for what? It is for taking the CSF out. What is the normal color of CSF? Normal color of CSF is colorless, or you can say what? It is colorless or transparent. So when you are taking this CSF out in a person who is having subarachnoid hemorrhage, the color of the CSF, so you are taking the CSF out, the color of the CSF will be somewhat red or yellow color CSF. We call it xanthochromatic CSF. Xanthochromatic CSF. It is a very important finding which you are going to find in subarachnoid. The one clinical feature, one and only clinical feature which will definitely come in your exam, and this clinical feature is what, guys? Patient will always and always complain about what? Patient will definitely going to say that Dr. Sahab, I am having the worst headache of my life. The worst headache of the life. The worst headache of life is going to seen where? It is going to seen in my subarachnoid hemorrhage. This worst headache of the life is known as thunderclap headache. Done, guys. That's all for today. So we have completed our primary headaches as well as the secondary headaches, and as I promised, it will be done before 12 o'clock, so it is done before 12 o'clock. Okay, I want you all to revise everything, guys, so once you will do it, will be easy. Okay, only topic which is remaining for discussion, it is the GIT, which we will do either tomorrow or on Saturday. We will put the poll on Telegram, and then I want that it is the last class, it is last live, and it will be like it will be of very long period of time, right? So I want you all to join that live. It will be around 3 hours of live. We will take break in between for like 15 minutes. Rather than that, I want everything should be completed until Saturday so that you will get time on Monday or Tuesday. And from 4th, we will start having the exams. Please prepare everything, whatever I have taught you in the live sessions. All these things will be enough to get 60 marks in Viva. Okay. Have a nice time. Bye bye.